morning. My name's Simon Mullins. I'm a survivor and also a consultant psychiatrist. Thanks to Bob for inviting me here today. I feel very privileged and very nervous as well, actually. Am I the only psychiatrist in the room? Oh, great. Another one. Good. You don't know what it's like sometimes, the conferences you go to and you're the only psychiatrist. It's I suppose it's important that I get to feel how it is to actually be a patient sometimes. So I work in a community mental health team in Sheffield. The last 3 years I've worked under a diagnostic kind of umbrella of psychosis, bipolar, schizophrenia. Thankfully that sort of diagnostic constraint is being opened up in the next year or two, so we can focus more on needs rather than a label. But in the last 3 years, specialising in this area, I came with a lot of traditional medical training behind me, but also more of an interest in sort of psychology and social aspects of mental health. And it became more and more clear to me that almost every single patient I was seeing, I use the word patient, and it's because it's a label that I will sort of talk through. They had a history of abuse and often sexual abuse, but obviously sexual abuse doesn't come in isolation. No, not yet. So I had this moment, I think, in a CPA meeting, a care program meeting, where this man, I think in his sort of late 20s, had been diagnosed with schizophrenia and had been in and out of hospital and sectioned. And we were discussing his care, and he had a history of voices and paranoia, because voices and paranoia are the experiences that often represent this kind of concept of schizophrenia. And as he spoke about his experiences over the years, it also came out that he was going through a legal process of prosecuting a perpetrator of sexual abuse. So I started to talk to him and say, you know, a lot of your experiences, voices, paranoia, your anger, your aggression at times, you're sort of feeling overwhelmed, your low mood, well, they're often the consequences of sexual abuse. And nobody had ever made that link for him before. They just said, you're schizophrenic. And I think there was a lot of good stuff in his life, but I think I just felt quite that link for him was quite important. And then I saw him a year down the line, and he still had voices, he still struggled, but he was calmer in himself somehow. And a lot of other stuff had gone on, but I think just that sort of validation was really important. So that sort of spurred me on, I think. But I had this kind of knowledge that I needed to find like-minded people, really, I think, because when you work in the system, there is a kind of a blind eye to abuse. Maybe I don't know why, but I don't have the definite answer, but hopefully we'll explore it together today. So rather than jump into like some science, I thought I'd start with maybe a metaphor, I suppose, for what it might feel like to be a man who's been sexually abused and is having care through the NHS. You know, I don't want to put people on the spot. How many people kind of know this story? So a few.
I know the Kafka one.
Yeah, it's Kafka. It's Franz Kafka. He was a writer who lived in Prague. I think he was a German Jewish chap who moved to Prague, and so he knew what it was like to be alienated, which is the theme really of this story and a theme of his work. And he speaks a lot about what it's like to be a victim of an absolutely crazy system. One of his stories is the trial, where a man is put on trial and he doesn't even know what he's supposed to be accused of, but he has to defend himself. So I read this book as a teenager. Oh, well, it's a short story really, or a novella. And I just picked it up in the library because I thought the name was interesting. And the first sentence of this story, I think, is the best first sentence of any story ever. But it says, Grigor Samsa awoke from uneasy dreams to discover that he had been turned into an insect. And there's no backstory to it. That's what's absolutely incredible. It just starts like that, and it's all about his reaction to his predicament, and more about how the people around him, his family and his community, react to him. And I think I'd urge you to read it and think about how it might feel like to be a man who's been abused and is in a psychiatric hospital or is trying to access help for his emotional problems, and nobody's actually sort of saying, how have you been turned into this then? What's happened to you? Because that's what the theme of my talk will be. It's about that we lose the narrative, and the most important narrative for many people that I see is that they've been abused. In the story, he's seen as a monster. And how many men sort of feel like they're turned into monsters? But his sort of dialogue he's very dignified. He just sort of accepts his plight. He tries to get dressed and go to work. So David Cameron would be very pleased. He'd be off benefits, wouldn't he? So he's got this dignity, but his family are appalled. And then his boss comes to visit and says, we don't want anything to do here. And I think really important for like male survivors, he finally dies and he receives a fatal wound from his father. His father throws an apple at him, and that's his fatal wound. So, moving on to my profession, which I'm kind of ambivalently attached to, I guess. But I still think we have a lot of good that we can do. I think it's important really not to sort of stereotype psychiatrists. As psychiatrists, we're here. A lot of us share very sort of similar values to other professions and the sort of the third sector and voluntary sector and society. So it's important that we're not stereotyped. We have a massive influence in our profession. That chemical structure. Anyone a chemist? It's chlorpromazine, so it's the first sort of broad psychiatric drug, variously described as an absolute saviour, emptied the asylums and also ruined people's lives. So it's and then on the other end of the scale, we've got sort of psychoanalysis. So we've got these massive influences, and as I think that reflects the nature of the business. We're trying to heal the mind, which has diverse influences and is also interacts with the brain in ways that we still struggle to understand and will always probably. But the medical profession is obviously based on a medical model, and the heart of the medical model in physical disease is to get to the diagnosis. It's, has anyone seen House? There's just that kind of fervour to get the diagnosis and to be that kind of self-gratification because you're cleverer than all the other doctors, But where we've got the psychiatry, because we're dealing with the mind, not a physical organ, although I think it sometimes gets mixed up like we are just dealing with the brain. We're actually dealing with the mind. The diagnostic system has kind of just grew and grew and grew. And we've now got, thank you to Hugh Middleton, another sort of like-minded psychiatrist, for giving me this slide, but there's 357 diagnoses in our sort of classification system. And there's probably only one or two which is based on any sort of genuine etiology, other than the sort of physical diseases that can cause mental health problems. There's only a sort of post-traumatic stress disorder that's based on an actual etiology that we can say for certain we know. Because etiology is more important than the diagnosis, because the etiology is a medical term for the cause. What's the underlying cause of someone's symptoms or experiences? And that's what's so sort of fascinating and interesting about sort of psychiatry, is that there are literally dozens of risk factors and identified possible causal factors for something so widely studied as schizophrenia, a condition characterised by voices and paranoia. From very sort of biological causes, you know, there are some genetic studies that show there's a genetic influence. There's brain factors at play. But there's also sort of quite profound social factors like immigration, alienation, being brought up in a city. You're at high risk of these conditions. So I found a study that kind of tried to tease out what might be the sort of prevailing culture within psychiatrists when we're sort of meeting people with two of the most sort of commonly diagnosed disorders. Depression, I mean, lots of people who've been abused will identify with low mood, surely. And schizophrenia, a feeling of sort of a breakdown of the self and a loss of identity, a breakdown with the barrier between the self and the world, an experience of voices and paranoia. Again, very much you could link that with an experience of being abused and it never being sort of dealt with. So, quite a small study really, but I think interesting. 154 psychiatrists returned a survey to say, well, what they thought were the underlying causes of depression and schizophrenia. Anybody wants to proffer the sort of most common result? That's psychiatrists. I'm looking to a fellow psychiatrist. Can you guess, is it going to be sort of urban life, or is it going to be sort of brain disease? That's the story really. But there's other things to it as well. We're not all stupid. You know? We're able to think through complicated things. So this is quite a complicated slide, but what it shows is lots and lots of factors that contribute to those diagnoses, from family history and genetics, very, very sort of hardly valued in the psychiatry profession that they're important factors. All the way down to supernatural explanations. That surprised me, you think. If the psychiatrist said that there was a supernatural explanation for someone's voices, wouldn't they then get sectioned? I don't know. But still, at least one thought it was. But I don't know whether that includes more spiritual things. Maybe that's just a silly word to use for more spiritual beliefs, I think. I don't know the authors, but what I wanted to point out, so it's diverse, and so psychiatrists have lots of different views, and we have lots of things to draw on, and it depends on what you value most, or what your experience, or even what your training has been, or you know what your awareness is. So focusing on today's talk, really, childhood factors, so that includes abuse. Interesting thing there, if you're diagnosed with depression, so if you present saying, I'm really unhappy, doctor, you're more likely for somebody to take notice that something might have happened in your childhood. If you present with, I hear voices, or I'm paranoid all the time, you're much, much less likely for anyone to think that that's got some link with your childhood experience. So I think that's quite illustrative of the problem.